Yeah, good evening, everyone. Thank you for being here. My name is Jasmine. I'm a consultant in pediatric dentistry. I know that when you're managing a condition like osteogenesis imperfecta for your child, dentistry can feel like sort of one extra thing that maybe you're not too sure about or you're not getting too much support about. And you're all aware of the importance of dental care. I mean, even from what Fiona was saying, we know it's important and we know it can be a little bit challenging. So today I want to give you practical, straightforward information that you can use when you walk into a dental clinic with your child. And what I hope you'll take away from the next 15 minutes or so is first, you'll know where to go for your child's dental care, and crucially, you'll know what your rights are when it comes to accessing specialist services on the NHS. You'll understand the most common ways OI can affect the teeth and the jaws, because knowing what to look for means you can spot problems early. And third, to help you feel more confident advocating for your child at dental appointments, because you're their best advocate. So the more informed you are, the better equipped you will be. I see quite a lot of children with OI at the Eastman Dental Hospital, and some of the questions that we hear often are the right questions to be asking. So where can I take my child for their normal checkups? What am I entitled to? What dental problems should we expect? What about bisphosphonate treatment? Does that change anything? And what does dental management actually look like in practice? So first thing, Emma's mentioned this, but it's really important to know that all children under 18 will receive free NHS dental care. No charges, any NHS dentist until their 18th birthday or until their 19th birthday if they're in full-time education. So if your child's not registered with an NHS dentist, that's what you need to do. But I know that it's much easier said than done at the moment. It can be really tough to find an NHS dentist. But unlike with your GP, dentists don't have a catchment area, so you can register at any practice convenient to you, and I would encourage you to do so. And if they say they're not accepting new patients, ask to be put on a waiting list. So why does seeing a dentist regularly particularly matter for children with OI? Well, again, Emma's mentioned this, but about half of children with OI have a condition called dentinogenesis imperfecta, or DI, and other dental differences that can make their teeth more vulnerable to wear, pain, and infection. And so the point is that they'll need more attention, not less. In terms of when to start, in England, we have an initiative which is Dental Check by One. So we would hope that by their first birthday, their first tooth would have come through and they can go see the dentist. And then checkups are recommended every 3 to 6 months, which is more frequent than an average child because we want to catch any problems early. And x-rays are taken every 6 to 12 months from around 5 or 6 years old, if possible, depending on what we see. And it can help us improve our clinical image, so improve what we can actually see in the mouth, but also find problems which we can't see when we look inside your child's mouth. This slide is important, but it's just something sort of quite practical. So every time your child sees a new dentist, whether that's an emergency appointment, they're going to a new practice, or you've been referred to a hospital dental service, make sure you tell the dentist your child's OI type, if you know it, what medication they're currently on, and whether that's infusions or oral medication, vitamin D, whatever that might be. Contact details for your OI specialist team so the dentist can get advice if they need it, and any upcoming bisphosphonate infusion dates, because the timing can matter for certain procedures. And it's also important that you tell them what previous dental experience they've had. So I don't just mean treatment, but have they had a cleaning? Have they had fluoride varnish? And have they had x-rays? So nothing gets repeated unnecessarily. And it can make a difference to the care your child receives as well. So dental care with OI works in steps, and knowing the system can help you and your general dentist navigate it. So step 1 is your high street dentist or your general dentist, and that's where your child should be registered, and they'll handle routine checkups, prevention of dental caries and that sort of thing, and even simple fillings can be done at the high street dentist if needed. Step 2 is the community dental service. So if your child has anxiety or a little bit more support, needs a little bit more time, or needs inhalation sedation, so like the happy gas or the laughing gas, then your general dentist can refer you there. And they will manage dental decay, they will do simple treatment, and they're very experienced with children who have additional needs or anxiety. And step 3 is hospital pediatric dentistry, which is where I work. So this is where we manage the most complex cases. So patients who have DI or other dental anomalies, children who are really anxious or need treatment under general anesthetic, cases that need multidisciplinary team approach. So what that means is there might be quite a lot going on. So they might have some things like they need fillings, or they might need some braces and some surgery. And so all of us will come in a room together, ourselves, the orthodontists, whoever is needed, and we'll plan it as a team, not individually. And children can also be referred to hospital pediatric dentistry for screening of DI and other dental anomalies, and to provide advice to their general dentist. One thing that's really nice in pediatric dentistry in pediatric services is that your medical teams will usually have quite good links with hospital pediatric dentistry teams. And so your OI team can support and refer your child directly. You can't self-refer to hospital services, so you do need a referral from your dentist or your OI medical team. But you're entitled to ask for that referral if you think that there's something going on, or if your dentist isn't confident managing them, or even if they just need a little bit of advice. So ask for the referral, and hospitals like ours can just write advice letters to support your local dentist in delivering safe care. So how can OI affect your child's oral health? We think about it in 3 areas. So it's the teeth themselves, the jaws and the bite, which Emma mentioned, and then impact on everyday life, which is what we call oral health related quality of life. And I'll go through each of these. The most significant dental association with OI is dentinogenesis imperfecta. So I'm sure most of you will know about this. Some of you will have it, and some of your children will have it, because around half of children with OI are affected, and it's more common in certain types, particularly in type 3. But what is DI? So simply put, it's a condition where the inner layer of the tooth, which we call the dentine, doesn't form properly, and it can affect both the milk teeth and the adult teeth, although the milk teeth are usually more severely affected. And it looks a little bit like this, but it can have a different appearance. So you might notice some yellow-brown discoloration or some blue-gray discoloration. It can look normal, so normal-looking teeth don't rule out TI. What happens is, because the inner layer is quite weak, the teeth will chip and wear down much more easily than usual. And Fiona has mentioned this, so it might be that people in her family have had a similar condition, or even a subclinical version of this. And on x-rays, we can see the nerve spaces inside the teeth, which are meant to be quite large in children, are often much smaller, which we call obliteration. And in rare cases, you can actually just get infections without having a cavity, and that's why those regular x-rays are so valuable, because that can show us before there's pain, before things get uncomfortable, and before things get uncomfortable for your child. And as I said, it's not always obvious just by looking, so referral for specialist opinion, for specialist screening, and x-rays are important rather than waiting until something goes visibly wrong. Beyond the eye, there's a few other teeth problems that we see more commonly in children with OI, and Emma's mentioned this. So hypodontia, which is missing teeth, they just don't grow. It's common in children who have DI and tends to be associated with more severe OI types. You can get teeth that are stuck, so impacted or ectopic, particularly sort of your back molars. And there's some evidence that it might be linked to bisphosphonates as well. And finally, dental decay, which is found in about 30% of children with OI. It's not caused by DOI, but children with DI might be more susceptible. But remember, decay is actually very preventable with the right diet and oral hygiene routine. And your dentist, even if they're not confident managing somebody with OI, they can still give you that preventive advice. They can give you diet advice. They can tell you what a good oral hygiene routine should be. I'm going to really briefly go through this because Emma's gone through it in a lot of detail, but OI can affect how your teeth develop and how your jaws sort of sit together. And you've got the class 3 bite, which can be called an underbite, which she's described, which is when your lower teeth sit further forwards than your upper teeth. Or you can have an open bite where your teeth don't touch. Or finally, you can have teeth in the wrong places, which are crowded or crossed together. And some of these issues might need braces, either locally or within a hospital service, but you can still have braces even if you're on bisphosphonates. So I want to spend a moment on this because I think it's not talked about very often, but a few years ago, our team at UCL, together with the team at Great Ormond Street, I looked at 106 children with OI to examine how their oral health affected their daily lives. And what we found was that many children, even those with milder OI, reported real difficulties with eating, speaking, and confidence because of their teeth. And we noticed that the severity of OI wasn't a reliable guide for how badly affected children felt. And some children with mild OI had very poor quality of life scores related to their teeth. So it's a reminder for dental professionals to never make assumptions and to take it seriously if you or your child tell us that they're struggling with eating or with the appearance of their teeth or how they feel about their smile. So if you think this is the case, raise it with your dentist or with your specialist team, and they can refer if necessary, or even just do simple treatments that can sometimes really help improve how somebody feels about their teeth. So what does dental management actually look like? With managing dental decay or dental anomalies, it does start out at your NHS dentist, and they can provide preventive care, things like fluoride varnish, which is a paint that can just be applied onto the teeth really quickly. It takes about 20 to 30 seconds, depending on your child's cooperation, and it's good at preventing decay. Things like fissure sealants, diet advice, and simple fillings and monitoring for DI, tooth wear, or your orthodontic needs. Referral to hospital pediatric dentistry is appropriate when there is anxiety that prevents treatment at the dentist, or they need multiple complex extractions or other complex treatment. We can provide inhalation sedation, intravenous sedation, or even general anesthetic if needed. And if there's DI or anomalies that need specialist management, then at the hospital, we've got a wide range of options. Just want to talk a little bit about how we can manage DI. So in the milk teeth, we would often do little stainless steel caps. So you can see in this picture here, they're literally little metal hats that we can put onto the teeth, and it seals all of that in so that the teeth don't chip away. It means you can keep your baby teeth for longer, which obviously is what we would always want if possible. We can even do tooth-colored fillings on front teeth or veneers. And for older children with permanent teeth, we've got options like tooth whitening. Although it does take a while, it can work and it can really improve the appearance of teeth. We can do veneers and we can do white fillings. Our goal is to protect the teeth, particularly when the children are young, and then as they're getting older, improve how they look and how they feel. And bisphosphonates is something that I'm sure you think about, but Emma's mentioned this, dentists worry about as well. And it's not just orthodontists, it's your general dentist. And the evidence is very clear that although children with OI receive bisphosphonate infusions, things like pamidronate, zoledronate, there's no evidence that you can get medicine-related osteonecrosis of the jaw for children with OI. And basically, we've got these guidelines, which Emma's mentioned, which are the SDCEP guidelines, and they classify children with OI on bisphosphonates as low risk because there aren't any cases documented of children having extractions or treatment where it's caused medicine-related osteonecrosis of the jaw. So if you do need treatment, or if your child needs treatment, there's no need to alter the treatment plans just because they're having bisphosphonates. Sometimes we might think about timing, and some guidance suggests avoiding invasive dental treatment 24 to 48 hours immediately following an infusion. So just thinking of it as a sensible precaution. But again, just letting your dentist know about the infusion dates, and that can help them plan. And if your child's cooperative, then simple tooth extractions can be carried out at your local dentist. If there's any concerns, then they can be referred onwards. And there's a little bit of evidence that bisphosphonate treatment can increase the likelihood of developing dental anomalies. Orthodontics, again, your child can usually have braces, so speak to your local orthodontist and be referred onwards if necessary to someone like Emma and her team. And a few take-home messages that I want you to walk away with. So first, if they're not registered, try and register your child with a NHS dentist from age 1 if possible for regular checkups. You can ask for a referral to a specialist at any time if your local dentist isn't sure how to manage your child's teeth, or if they want advice, or if your child needs hospital dentistry care. Bisphosphonates do not cause jaw problems in children with OI, and the evidence is clear on this. And OI affects dental development in a range of ways: DI, missing teeth, jaw differences, but also your child's oral health related quality of life. And if they are having difficulties, mention it and get the help that's needed. So thank you very much for your time and attention, and I'll answer your questions later on when we've got the Q&A session. But yeah, thank you very much.